national research. So now a little bit about what Montgomery County is doing, and they can talk more about it more specifically. So at the beginning of telehealth, it's my understanding, or the beginning of the pandemic, it's my understanding that HHS, each department or each service area and program did what they had to make it work for them. So any services that could be provided virtually were, but some obviously cannot be provided virtually. So they each kind of did their own thing to make it work for what their needs were. And talking to staff, there were two main challenges for them: access to broadband services for their staff and for their clients, and then also language barriers were a big issue. So during the course of the year, HHS had formed a work group that addressed the implementation of telehealth, and Dr. Rogers was the head of that, and he can tell you more about where that stands. But the work group did recommend the implementation of Zoom Health as kind of a comprehensive way to provide telehealth through HHS. So I believe that is further along in the process from when I did the report in December. So lastly, I had two recommendations for council action. One is that the council can talk with HHS staff about advocating at the state level for certain changes that might be temporary. Things like payment parity and regulations on licensing and covered services. All of those things might change a year from now. And so you can work with HHS to figure out which of those policies they would like you to advocate for that could provide greater equity among users. And then second, another concern that DHS staff were telling me about were that their staff need more technology and need more Zoom Health licenses and things like that. And so the council can support HHS in providing those technology needs for the staff, but also their clients and users. And one of those key impacts was the language issues and kind of figuring out how to do that in a more efficient way. So that's really the report. It's, that's kind of a general overview. And I can turn it back.
That's super helpful. Thank you, Ms. Latham. Dr. Rogers, you want to tell us about the work group? I am familiar, at least initially, with at the outset, the framework that the team used to help develop a guide, because there frankly wasn't one in the way that we really needed, because this is new and emerging. Although it's been around, it's never been accessed at quite this level. And so hearing what some other jurisdictions are experiencing with the possibility of exacerbating a tough situation, what steps have we taken and are taking to make sure that doesn't happen here?
Yes, good morning, Councilmember Vice President Albernos and Councilmember Glass and Rice. Councilmember, do you mind me sharing a brief 5-minute PowerPoint that will walk you through some of those items that you just mentioned?
Yeah, go ahead.
Okay, perfect. So hopefully you all can see my screen. We all are aware that COVID-19 has really exacerbated the need, the use of telehealth for mental and both somatic care. And so, so the department and executive branch, we fully concur with the recommendations that have been outlined in OLL's report. We all value and we agree that telehealth offers many benefits to providers and clients and patients. For example, in COVID-19, ability to use telehealth for infection prevention, the ability to use telehealth for better coordinated care amongst providers at disparate sites. We also agree that access to technologies is essential, specifically having broadband and smartphone access for many of the telehealth platforms that are available, such as Zoom Healthcare and Doxy.me, is essential for our most vulnerable populations and communities throughout Montgomery County. Now, digital literacy has also been a concern, and so there is a definitely need to address digital literacy, not only with our clients and patients, but also with our providers. If providers are not able to utilize the technology meaningfully in order to deliver that telehealth care, and then the patients and clients cannot benefit from it. And so training and technical assistance, as the OLL report has highlighted, is also essential. Our language access for individuals who does not speak English is also very important. Those who speak French, Amharic, Spanish, and those other prevalent languages throughout Montgomery County is also important. And video remote interpreting is also essential. Now, privacy and patient safety is imperative. There's some flexibilities that the federal government has granted to providers when it comes to privacy and patients for those patients who may not have access to a smartphone to access HIPAA-compliant platforms, and I'll talk about that a little bit more later. And then funding and adequate reimbursement is also essential for sustainability. Now, on your screen here, you see a matrix table of the use of telehealth across the Department of Health and Human Services. As you mentioned, Council Member, and as Kristen mentioned earlier, we formed a work group in DHHS as part of our recovery efforts to really examine the use and the purpose of telehealth across the department. We identified those service areas that could potentially utilize telehealth and that ultimately are utilizing telehealth. And we had key representatives from across the various service areas to really flesh out the recommendations that we made to the director, which I will cover briefly. And as you can see, we have a broad range of programs and services, and we're mainly using two telehealth modalities. Synchronous, when we talk about telehealth, people normally are thinking about synchronous. That is your Zoom Health, where a provider logs on to Zoom and a patient logs on to Zoom on the other end, and they're able to provide communication and care real time and live. And telephonic and audio only. Telephonic is very important, especially for those patients, those clients in our community who do not have access to broadband or very limited, spotty access to Wi-Fi or may not have a smartphone. So the department has taken aggressive efforts to ensure that we have achieved telehealth equity. We studied this very closely as part of our HHS telehealth work group, and we made several recommendations. Again, I'll talk more specifically about those in the next slide, but we have, there has been expanded access to communication modalities. We talked about Zoom Health. The HHS work group looked at a number of different platforms that are available on the market, and we decided that Zoom Health will best meet the needs of our department, of our patient and clients. For those patients and clients who may not have a smartphone, et cetera, to access Zoom Health, we are granting flexibility for providers to utilize a non-public facing remote communication platform, such as Microsoft Teams, that still allows that end-to-end encryption and still ensures safety, where only the patient will be able to access that particular visit with the physician. I mentioned about telephonic and remote patient monitoring. Remote patient monitoring is pretty much key when it comes to, for example, Montgomery Cares and the flexibility there. We do provide technical support for both clients and patients who have digital literacy. For example, staff may need to log on a little bit earlier for certain programs or services to ensure that our patients or clients are able to log into the Zoom Health or to the Microsoft Teams visits. We have Telehealth Hubs, for example, behavioral health. I'm aware that they have stood up Telehealth Hubs throughout the county where patients can go to access computers and tablets for free to ensure they are able to get their mental health care. I know in CYF, Children, Youth, and Families, specifically infant and toddlers, they have provided computer equipment, I believe it's tablets, to their families in order to receive health care. We also have the use of interpreters from Voyance, which is the county's language services that provide remote interpretation services. And we, of course, we have engaged with our caregivers as they may need to support their patients and our patients and clients with accessing telehealth services. And then finally, these are the recommendations that the county, that the department are putting forth to guide the county's implementation of telehealth. And additionally, these are many of the recommendations that the HHS Telehealth Work Group has made to the director, and the director has taken these recommendations up. Some of them have actively been implemented, and some of them are actively in the process of being worked on. We developed a telehealth policy. It was important for us to standardize the use of telehealth across the department so that everyone can ensure that there's safe use of telehealth for our broad range of services. We talked about Zoom Health, which is the HIPAA compliant telehealth platform that we recommended. We also developed a comprehensive telehealth informed consent so that we can ensure that all of our providers across the department are utilizing the same informed consent. I talked a little bit about video remote interpretation, telehealth quality and equity of care. I talked a little bit of previously slide about equity of care, but we continue to monitor quality. Monitoring quality is something that each service area has been monitoring, but is essential as we go forward that collectively as a department, we continue to work together to ensure that we are optimally using telehealth services. Now, there are also provider level recommendations. And so, as I mentioned earlier, it's important to ensure that our providers are able to meaningfully use telehealth. And so we have ongoing training and technical assistance. For example, Zoom Health has provided large trainings to our team, and they are ongoing. We also have upcoming training on the use of the video remote interpretation services. It's important that clients and patients are able to complete the necessary forms from their home while they're receiving telehealth services, so they don't have to just screenshot the form and send it to the provider. And so we want to ensure that providers are able to send patients forms online to complete. We also, many providers do not like to utilize multiple systems. Providers like to stay within their EHR, they like to stay within their EMR, and they like to ensure that all of the technology, the software that they utilize are at their fingertips. And so we've made several recommendations to the director to integrate Zoom Health with existing IT systems so that the provider can spend time in the EMR talking to the patient, but still able to access much of the needed resources or existing systems that they may need to. And we also wanted to standardize the use of documentation to ensure that documentation is both timely and accurate. And so we have made recommendations on the use of my phrases and smart notes so that the patient can document key phrases or key notes that are prevalent to telehealth. And then again, as a county, lastly, we agree with all of those recommendations that we want to advocate for telehealth laws that have been enacted during the pandemic, and we want to advocate for more telehealth hubs and greater broadband access. With that, let me stop there and take any questions that you all may have.
Thank you very much, Dr. Rogers. I want to give both Dr. Brunetto, or Ms. Brunetto, and Dr. Santiago the opportunity to provide information. Understandably, I know all of us are concerned about the equity divide, and understandably our older generations maybe not being as comfortable with that technology. Ms. Brunetto, from your perspective, what strategies are we taking? What more do we need to do to help close that digital divide? I'll give one small example. One of the programs that I'm super proud that we stood up while I was at Recreation was the program called Tech Connect, which Councilmember Rice was a huge champion of and helped us get funding for, along with Councilmember Navarro and Councilmember Reamer at the time. But programs like that really make a difference in teaching youth, teaching seniors about technology. That made a huge difference. What strategies are we taking to help close that technical divide within our senior population?
Thank you so much, Vice President Alvarez. Good morning, everyone, the council members and team members. So yes, the Tech Connect from the Recreation Department has been a huge success. And we modeled the work of the youth and older adults when we had our COVID core back in the summer last year. Those were young people who were able to be paid for a couple of months during the summer, and they assisted online, meaning on the phone, older adults who indicated that they needed help using the technology that they had. That was extremely successful, the COVID core, and the core was able to function from July to October with federal funding. So we would clearly want to see if we could do something similar again this summer with youth who could continue the COVID-19 core to assist older adults and persons with disabilities with one-on-one, on the phone technology assistance. And the Recreation Department Tech Connect, that is done in partnership clearly from our wonderful colleagues in the Recreation Department and with NCPS. So this program is being explored for further expansion, and we are working with our partners, again, in the Recreation Department and the public schools to see if our youth could obtain credit hours for assisting older adults and persons with disabilities with technical assistance over the telephone. I have to say that in aging and disability services, we have right now 49 of our employees who are actively using Zoom Health, and everyone is reporting a very high rate of success and satisfaction. For example, with our developmental disability community, we see that our case managers are able to conduct the business of developing a plan of service, discussing with families what's happening, and families are extremely happy with that, and the program participants as well. The Zoom Health is accessible on people's cell phone, so even if you don't have a laptop, etc., with your cell phone, you can totally engage in communication, discussion. People can share documents with each other. I had a wonderful story about a person with a developmental disability who has a brother overseas and has not been able to discuss anything with the brother for months and years. And now they communicate regularly, and they are engaged, and they are really enjoying this way of communication. We also have some of our clients in our adult foster care, our public guardianship, who are also engaged with Zoom Health with our staff members, as well as participants in our Medicaid-funded community for life program with adults who are receiving services in the home from a nurse and a case manager. So we are clearly very happy to be able to continue to expand this service and continue it post-pandemic for those families and constituents who would like to continue to do business with us that way. We also have received a small grant from the State Department of Human Services in Baltimore. They have provided for 32 devices for our population who obviously cannot afford it. And so we receive those items in December, and we have trained our staff and our clients on how to use it. Those items are voice controlled. They have a screen, an 8-inch screen. And again, this is very successful, and we have just been informed by the state that they are going to expand this pilot and give us 60 additional items. So we are very appreciative of that. Do you have to take any questions?
Thank you, Dr. Brunetto. I think that's all really good news, moving in the right direction. I think it would be good for us to maybe establish some goals and benchmarks of how many seniors we want to try and target in the upcoming years. I think that would be appropriate, particularly since our aging population is the fastest growing demographic in the county. And I wonder if there wouldn't be some value in conducting some surveys and analysis using some of the tools we have to find out how far the digital divide is. Because I will say, I think that, everybody has become a little bit more comfortable with technology this past year. And so it would be interesting to check where folks are and then have that serve as a baseline for us to establish those benchmarks. Because I think if done right, this could really contribute to closing that equity gap, particularly in our aging population. Dr. Santiago, the other potentially positive applications for telehealth and telemedicine are in behavioral health for obvious reasons. And telemedicine and telehealth was growing prior to the pandemic as a tool and resource that was used in the field more often than in primary care. What have you seen this last year as potential options? Just as a specific example, we did also get a briefing recently in the Public Safety Committee in which we've piloted a program through Fire and Rescue in which we've outfitted some of our ambulances within one specific fire district, fire precinct, to provide telehealth and telemedicine options, and so that we can avoid having some folks have to go to the emergency room and maybe going, and being diverted to a more appropriate location where they can receive even better and more holistic care, keeping the emergency room truly for emergencies. So a lot of potential applications, but could you share with us your thoughts from a behavioral health standpoint on what you see as the pros, cons, and something to consider moving forward? Oh, you're on mute, Dr. Santiago.
Thank you. Thank you again for the opportunity to speak, Council Vice President Albornoz, and it's good to be here with Councilmember Glass and Rice as well. The pros is definitely increased access. It has become almost the modem of operation in terms of providing therapy right now throughout our services, adult and child and adolescent and so on. So we hope that going into the future post-pandemic that we will continue to offer these services through telehealth, and that parity in payment will continue. Of course, as was mentioned already, a lot of it depends on state and federal laws of what will be reimbursable or not. But our recommendation is to push for continued parity in the use. I've heard many stories, good stories. The use of smartphones has been really quite revolutionary. So the cons that I see is the digital divide, and also the fact that it has been somewhat difficult to get to some of our communities of color, if you will. The way that our staff have tried to deal with some of those disparities, and some of it is a fact that they don't have access to technology, and then the language barrier, getting the information, that there's technology in the libraries or in the hubs that they could access. That requires almost someone that is speaking, accessing, and reaching out. So we do have, I know that in child and adolescent behavioral health and in some of the other services, we use the liaisons to these communities. So I recall a situation with a Vietnamese community. We have a very good liaison to that community who visited an individual in the aging population that required assistance, and the liaison found out that person didn't use technology, had trouble with the language, and help facilitate then that kind of the interaction using telehealth. But I imagine that's just one example, but I think it repeats itself, not just with the Vietnamese community, but with the many other language communities that we have here. One of the reasons that should be underscored for the use of Zoom Health in particular is that it does have the tool to have simultaneous translation. So you can have an interpreter on a call. And of course, you need to have the consent procedures and HIPAA compliant to do all of that. But that's a very important reason that will help create that kind of access to telehealth that we should be reminded. I'm looking forward to discussing with staff how frequently they're using that feature within Zoom Health. So I think the story is that the pandemic pretty much forced all of us to use telehealth, and it has been a good story to tell in terms of access, and we hope that it continues. We continue to use those tools.
Thank you, Dr. Santiago. As you were talking, I just had a thought that, you know, the opposite issue is true with youth as it is with seniors. Youth are more comfortable using technology and prefer communicating in that fashion. And so this could be, and as we've heard from experts in the field in the youth development space, which is near and dear to my heart, they've actually seen an enhancement in some of the engagement, at least with some youth, even during the pandemic, because of, you know, their ability to access technology. So I think as we transition through these lessons learned, it's not a one size fits all, but, you know, can be positively applied to certain demographics. Have a few just questions. So Dr. Rogers, thank you for your leadership in leading this subgroup. You laid out perfectly both the challenges and opportunities and the right framework to address this from a number of different levels. Do you have sort of like a wish list moving forward of, you know, technology being something that is a barrier, more people needing access to it? You know, this council will be taking up the issue of 5G later this year, which I'm on the record, and I believe Councilmember Rice is as well, as being very supportive of. And you know, it's one of those issues that does deal with equity on a number of different levels. But from HHS's perspective, what wish list do you have? We have this large round of federal stimulus coming forward. Can any of that be used to help set up an infrastructure for technology moving forward? Are there plans to use any of that, those resources and this unique opportunity for one-time funding?
Yeah, thank you for that question. I would answer maybe on the two different levels. One is, as my colleagues have stated, Dr. Burnett and Dr. Santiago, the use of these telehealth hubs strategically throughout the county would be very essential, where our patients, our clients can go and get access to computers or tablets, et cetera, to see their providers. Now, these will have to be designed strategically so it offers privacy, it offers security. In addition to that, we would need these kind of like telehealth navigators, we've been calling it in healthcare, that really stir or direct people to utilize these types of services, because not everyone may be propelled to go in to seek out that type of access, even though it's available. And so individuals that are kind of like on site that can help provide that guidance, that technical support once a patient and client actually gets to that telehealth hub is also essential. And so we want to look at, again, our most vulnerable communities, perhaps look at where many of our residents or clients are located that may have limited broadband access. It's going to be essential for the department as we kind of move forward. I would say on the other front, on the provider level, and so as we continue to look for ways I talked about integrating Zoom Health with some of our existing platforms. I know that there's some financial, some technical, and some other resources there that may need to be enhanced in order to move forward with that. And so it's important that as we continue to move forward, we engage our providers to see how can we better maximize the use of technology and these different integration options, and where there may be costs necessary, the support of the department and the support of the council is going to be essential for our providers. So when I think about video remote interpretation services, we don't anticipate there being a cost increase to that, because our contract will cover both telephonic and video interpretation services, and we've just mainly switched services from being in person or over the phone to being via telehealth. But that's something that we continue to monitor. And so I guess the takeaway is the telehealth hubs, and then at the provider level, there are increased costs to ensure that we continue to provide them with the accommodations they need. The training, the technical assistance, the access to the software will be essential.
I appreciate that. If you do have a specific, blueprint, plan, if you could wave your magic wand kind of a deal, I know I, for one, am particularly interested in seeing that, because I do think this would be a wise investment. We're working with the HHS team and public health team, and we'll have more information to share with my colleagues soon, but we are moving towards a public health summit in the fall. to take some of the lessons learned from this last year and apply them moving forward. And there will be an extensive discussion around telehealth and telemedicine. And so there's a hope that there will be firm recommendations coming out of that from a policy level and a budgetary level. So I think we've got some time to prepare, but that I think would serve as the perfect vehicle for HHS to move some of these lessons learned moving forward, because they have a dollar figure associated with them. I do have a question for you, Ms. Latham. I don't know if you can answer it or not, or the HHS team. So I know the policies and laws are complicated, mostly federal and state. And I know that there have been some bills in Annapolis this year, which the council is on the record as unanimously supporting extending the access in the short term for reimbursement and minimizing some of the restrictions to allow more people to access telehealth and telemedicine. But have you noticed, did you see, are there jurisdictions that are exploring what more can be done at the local level? Montgomery County is never bashful about waiting until the state and the federal government align. Are there steps that we can take in the short term to make this easier or enhance in some way what we're doing?
Well, I think at least I looked into several other jurisdictions in the area, and actually not many could provide me with any of what they were doing. They were very piecemeal about how they were doing things. But I did find, regarding like the laws, Maryland is actually one of the states that more of the regulations and policies that they put in place for the pandemic are more permanent than a lot of other states. In most states, it is a temporary thing. So at least in that regard, for some of the aspects of policy, we are farther ahead than others. But again, with the other jurisdictions, I was not able to find much of anything about anything.
We may want to follow up with Ms. Winger and our team to look at legislation, both at the national and local levels as well, or at the state level as well, just to see what we might be able to codify, because I do think that this is an area we should explore. But Councilmember Rice had some questions and thoughts, and Councilmember Glass has some as well. So Councilmember Rice.
Well, thank you very much. Excuse me. Thank you very much, Mr. Chair, and thank you. I want to double down just a little bit in terms of training, because, and I want to just give you a quick anecdote. My mother, who has a number of different pre-existing health conditions, had to migrate to normally seeing her doctor during the peak of COVID to transitioning to telehealth. And if I was not there to help her, stand up the technology, all she had was her cell phone. So, we actually bought her a computer because she was only using her cell phone to be able to utilize, and then showed her how she would do this. And still to this day, there isn't a day that goes by that I don't have to help her with an email that she's getting from Blue Cross Blue Shield about something that she needs to fill out some information and log in her blood pressure for the day or her blood sugar and those kinds of things. And that digital literacy is so important when it comes to telehealth. And without some sort of requirement around the fact of folks having to have this information, I just don't know how we truly achieve equity in telehealth. There has to be some requirement, whether it's on insurance companies, whether it's the onus is on us as local governments, whatever the case may be. But without that, I just don't know how we achieve it, because then you leave it up to the individual, and those who are connected are the ones who will get the service, and those who are not, who don't have the, who don't live with their children, who don't have all those kinds of things, will be the ones that get lost. So, I mean, what are our thoughts around how we can be more aggressive around this ultimate goal?
Maybe Dr. Rogers.
Yeah, so that's a great question, Councilman Rice. I think many of the things that Dr. Brunetto talked about earlier, and I'm probably going to defer to her when it comes to the older adults. But I think as providers, it's important for us when we are engaging with older adults to make sure that we're asking them about their caregiver support. And if they have caregiver support, making sure that we are engaging those caregivers when it comes to the training and technical assistance. proactively as a department, as a county, offering technology training classes like the county has been doing so lovely over the past year, at least since I've been with the county. It's also going to be essential. I think, though, we have to keep open the option of the ability to deliver telephone audio only care. And so when telehealth or technology is an issue, or older adult may not be able to utilize technology to their advantage, then being able to deliver that care via telephone is also going to be important. However, I do realize that there are some services or care services that aren't able to be delivered due to telephone, that will require that virtual, that physician or that mental health provider will need to lay eyes on the patient, on the client via video and via in person. And so as we continue to look for ways to enhance, provide innovation training to older adults, to their caregivers, that's going to be essential as we kind of move forward. Again, I'll yield to Dr. Burnett if she may want to add something also.
Thank you so much, Dr. Rogers, and thank you, Councilmember Rice, for sharing this experience with your mother. You may recall that the county has had for 5 or 6 years now a contract between the County Department of Technology Services, DTS, and a nonprofit agency called OATS, OATS, Older Adult Technology Services. They provide training to older adults and persons with disabilities on using all types of devices. Prior to COVID, the training was provided in person in different classes across the county government, either in the recreation centers or libraries. And obviously now everything has been switched over to do things online. And so they have done a fabulous job with weekly classes in multiple languages, Spanish and Chinese. And they continue to be very successful with a number of older adults and persons with disabilities who enroll in those classes. But as you know, we have to use multiple strategies to reach out to older adults. We need assistance with technology. One of the wish lists would be these telehubs, to have them located in many locations in our community. For example, the HOC senior housing, the multiple independent living housing buildings that we have in our county for older adults who are with low income. We could also open those hubs in the senior centers when the senior centers are able to reopen safely. So those would be some strategies that we can pursue.
And if I could just underline your concern, Councilmember Rice, I think it's really incumbent upon ourselves in HHS to ensure that this is, if not at the, that it be at the very top of our priorities. We know that Montgomery County is a very diverse language and ethnic and nationality, people with different national backgrounds and communities of color. I mean, we're very, very diverse, and access is a huge issue, even without the pandemic. And overlaid, you overlay the pandemic, and it becomes in some communities even worse. So I think it is incumbent upon ourselves to perhaps make it a focus of our attention, the inequities, and all the solutions that Dr. Rogers and Dr. Brunetto have been talking about, kind of bring them together in our discussions with staff. How can we just hammer at it? And almost it might require even weekly work group, weekly meetings. How are we getting to work to battle these inequities? So I'm hearing you clearly, and I'm taking notes and working with my own staff of how we can make this our top priority.
Well, thank you to both of you, well, to the three of you. And let me just say that one of the things that I think is incredibly important is for us to seize the opportunity right now. While I'm in the middle of our National Association of Counties national conference, and so I'm having these conversations and running point on broadband and why broadband is so important. One of the key tenets of broadband connectivity is telehealth. That's one. Economic empowerment and workforce development is the other, and education. So all of those things are in those buckets. And let me just say that this is a big part of the conversation across this nation, is about what needs to happen. And so if the time isn't now, I don't know when it is, in terms of us really putting the robust resources behind. So much to what Vice President Chair Albornoz has said, when it comes to, let us know what it is that we need to do to invest, to stand up, to ensure that these programs happen. Because what we've seen, and I know that you've seen this as well, I've heard it from AHP, I heard it from LHI, we've had more people connected to doctors than they have been before because of telehealth, right? To where it was so inconvenient to have to ride multiple buses to go see a doctor. But now they actually have the opportunity to do this. And while they may not know all the nuances of how to do it and how to do it right and get it done, they realize that this makes it easier so that I don't have to take off, 2-3 hours from my shift work to go get checked out, right? That I can do it and actually meet with a doctor and do those that's a positive for us, right? That actually helps us to bridge the health equity divide. And so if we get the digital divide part of this right, in terms of healthcare, we can actually make some really marked changes in terms of how people are integrating with their healthcare system, with their doctors and the like, and treatment. So from that perspective, we have so much to gain and so much to lose if we don't get this right. That's the reason why we just want to continue to push to make sure that we can get some great strides going and make this happen. So thank you very much for each and every one of your commitments. And thank you, Mr. Chair. I yield back to you, sir.
Thank you. Councilmember Glass.
Thank you very much, Mr. Chair. And just following up on Councilmember Rice's comments, just want to thank him also for his national leadership on internet connectivity through his work at NACO. And so clearly applicable to this conversation, and I appreciate you sharing that work and those conversations that you're having right now with the NACO conference taking place virtually as opposed to down the road. But so especially my colleagues have heard me from time to time talk about the work I've done a dozen years as a journalist. But in between journalism and now serving on the council, I did some work as a consultant, and I spent the better part of 2 years working with the Department of Veterans Affairs, specifically highlighting the telehealth work that they were doing. And I spent a lot of time for those of you familiar with the VA, in Vision 23, which is their area in the upper Midwest. So, I was traveling to tribal communities. I was traveling and visiting senior centers to talk about the VA and talk about how it had, in some circumstances, better coverage than private insurance. But 10 years ago or so, talking about telehealth, which had not yet been captured as a policy or as a way to do business with the private insurers, but VA was doing it, and particularly in the rural parts of our country, it was really important. And some of those conversations are applicable here. I'm hearing the same themes, because I know that when I went to the Pine Ridge Reservation, which is the poorest part of the country, the county in which Pine Ridge Reservation sits is the poorest county in the entire country, in South Dakota. And we were just talking about connectivity. and about hesitation and about other differences that exist. And so clearly we are not Pine Ridge. We're in one of the most wealthy counties in the country, but we certainly have pockets of need where there's either a disconnect, literally, or hesitancy because of cultural differences. And so I really appreciate this conversation and the direction that my colleagues have gone in to try and close that gap. I have two questions, though. The first one is for Ms. Latham, regarding the OLO report specifically. When looking at the work or the ability of the county in this area, how does that square with the private healthcare that is around here? What differences are we seeing in our ability to match the services as best we can? And then I'll leave it there and ask a follow-up if necessary.
Okay. I was looking into the research into like private companies. They were able to move quicker. Obviously, for obvious reasons. That was really the main difference. But like what they're using, and actually, I will give the county credit for like what they told me about how they're trying to reach the marginalized populations. We are actually doing more than health companies. At least appears, throughout the research. But yeah, they moved quicker just because they obviously have more fungible funds. So that was the big difference. But as far as operations go, they're pretty similar. Yeah.
So we know that the private entities work faster and are more nimble than government, right? That's a foundation we all agree upon. Although this last year has shown that we can be nimble and that we need to be even more flexible moving forward. But that is a baseline to know that we are at least using the same technology, if I understand you correctly, right? It might be implemented faster in the private market, but we're matching the technological needs.
Yes, and my understanding that looking at especially like local ones, Zoom Health is kind of the premier one that a lot of folks are using nationwide.
Well, that's great. That's reassuring to hear that at least the service level and the quality of service is the same. Really important, and I think that's another. Going back to the conversation I just shared, the story I shared about trying to do outreach and retention for the VA. That's another talking point, saying that our telehealth quality matches that of the private sector. So I think that's great. So thank you for that, and thank you for the report as well. And then the other area I would just like to dive in a little bit is, regarding the Telehealth Hubs, Dr. Rogers, in your presentation, and clearly the communities that are disconnected, they need connectivity. They need either the tablets, the computers, the video monitors, whatever it is, the camera lenses. And so just trying to understand how those come together, or how those physical equipment are provided to people. And the second part of that question is, as we are working with everybody within the health and human services sector here in the county, particularly I'm curious about the homeless services providers who, for the most part, their individuals don't have any of this type of equipment. And so talk to me more about that nexus of telehealth hubs and some of the communities where we know people need access.
So I think something that I failed to share is, so before I came to the government sector, working in the private sector up in New Jersey, a large integrated health system, we ran a pilot where we provided our patients with free tablets. But as long as they utilized them to connect, we had some standards around them, but we provided them with free tablets. And if anyone needed, we would provide them with hotspots to connect with the internet. But as long as they utilized the tablets to connect with their doctor, didn't miss any appointments, those type of things, they were able to keep the tablets and able to keep the Wi-Fi. Of course, the hotspots it was a cost to it subsequently, but the program, we paid for it initially for about a year or so. And we saw increased rates in the use of telehealth amongst our patients, and there were a range of ages, both adults and then your older adults, and then sometimes your old adults, those ones who may be like 75 and over. And so I think that's one, when we talk about a wish list, I think that's one idea that we may want to consider is in these vulnerable communities where individuals aren't able to purchase tablets, they aren't able to purchase computers, maybe they aren't able to afford the internet. How can we, provide greater broadband access, but how can we, help support that financially for some of our most vulnerable residents who may be under a certain poverty level threshold? And so, and the second point to your question, as far as the telehealth hubs, I think from an operational standpoint, it's a matter kind of like Dr. Bernetto stated, I think, as you highlighted, identifying those strategic organizations, we use this word place-based initiatives. I was in a call the other day about place-based initiative, these neighborhoods, right? Trusted organizations in these neighborhoods where we can build out rooms, where we can build out centers, where we can build out privacy. Of course, COVID-19, we have to be mindful of that, where we're able to provide, place tablets and computers there, ensure that there's access to the Wi-Fi and access to broadband, where residents can actually come to these physical locations, whether it's by walking in their neighborhood, or whether it's a resident or a neighbor or a friend or a loved one dropping them off, so that they can utilize these telehealth services, not only to see their provider, but maybe they just need to access a computer or tablet to conduct business, right? So we don't want to just restrict it.
And Dr. Rogers, just following up on that, did you find when you were in New Jersey that there were cost savings associated with that type of program because people were not getting as sick or not getting sick at all?
Well, we did not evaluate cost savings, but I did say we saw increased revenue because there were less. We saw better quality outcomes, and which can translate it to cost, while we did not specifically measure costs. And we saw increased revenue because we had less missed appointments. Right. And we also measured some quality outcomes in clinical care. And we saw some improvements in some chronic disease indications. Like, for example, one was A1C and type 2 diabetics, right? Them being able to connect with a community health worker, which is similar to a telehealth navigator, kind of what I proposed earlier, was also very helpful. And so in addition, Councilman McGlass, to your point, at these telehealth hubs, we're going to need individuals there that can provide that support. Whether it's a liaison from the department, these telehealth navigators, or where we can strategically have them travel throughout the community to these different locations to provide that technical support as residents come to access those technologies. And so we can place tablets, computer technology in these physical locations, or we can look at a model where we are where we're giving our most vulnerable residents tablets and things like that to ensure they're able to receive services.
And just so I understand it, I'm going to ask it a different way. So you had said increased revenue. I'll equate that to cost savings, right? At the end of the day, but the cost savings came because of staff time not needing to be there as often. Can you just elaborate on where that cost savings came from?
So the cost savings will come from patients not missing their appointments. And so if a patient missed their appointment, we're not able to, receive that reimbursement from Medicare or Medicaid. But however, when they do see their doctor, when they do see their nurse practitioner, et cetera, not only are we able to ensure that we're able to reimburse for those services, thereby cost savings or increase in reimbursement, but we also are improving quality outcomes, right? Because that patient is seeing their physician, they is seeing their doctor, they are getting treatment instructions, they are seeing a community health worker who can provide that follow-up chronic disease management, care coordination, access to social resources and things like that. So all that can take place as a result of that patient actually seeing their provider and those kind of next steps once that patient is no longer directly interacting with the physician, but that community health worker or telehealth navigator.
Very interesting. I know I'm all in support of getting people, making them healthier and trying to find cost savings. I know my colleagues and all of us on this Zoom are in that same interest, have that same interest as well. So certainly something I'd love to follow up with and try and see what more can be done with that. And the way the explanation for the cost savings about the reimbursements is my segue to my last question, and it goes back to the comment I made just about those who are providing homeless services and trying to understand what the nexus is between some of those nonprofit organizations set here and whether or not those nonprofit providers are reimbursed if they do engage in this type of telehealth. I don't know if it's you or Dr. Santiago who might be able to answer that.
It may be Dr. Santiago. What I can say is this. Prior to the COVID-19 pandemic, I volunteered for years at the Baltimore Rescue Mission. And I was surprised how many men actually had a smartphone or had a free phone. But I'm not sure how prevalent access to cell phones is in Montgomery County. But what I would say is that the homeless shelters would be another one of those strategic locations for a telehealth hub, right, where we would place tablets, greater access to tablets, computer technology, ensure that they have strong enough Wi-Fi so that the residents at the shelters are able to not only utilize the technology for their provider visits, right, but also in greater access to specialists and greater access to providers, but they're also able to utilize the technology to conduct business that they may need to over the internet. But let me defer to maybe Dr. Brunetto or Dr. Santiago, maybe if they want to add anything.
I've heard stories in the shelters that they are using the technology, and I'm grateful for that. But it's also we need to continue to underline that we could do a lot more with not just the shelters but the other hubs, and the two ways. And these are practical investments, and they will probably be one-time costs because once you have both equipment, and the other part of the equation is transportation for some clients to get. Now we're doing it, at least we're doing it in behavioral health and crisis services, but my staff tell me that we need more resources. So if there's anything that comes out of this work group session is additional resources for the transportation and also for the equipment, so that we can make it real. What we hope to happen in the hubs, in the shelters, and in this vision for creating access, especially in our communities of color, if you will.
Absolutely. Well, so I'll close on this. I'm intrigued by the possibilities, from how you described these operations. And Dr. Rogers, I'll correct the statement I said, and I said it was cost savings, but clearly, as you described it, is because of the reimbursement. It is actually more money that is coming in because of those reimbursements. And if Dr. Santiago is saying we need more funds to be able to do this, and those types of operations are actually revenue positive because of the reimbursement rate and because we're keeping more people healthy and safe, I think this is worth pursuing hard. And so I look forward to working with my colleagues and working with you to see what we can do to keep more people healthy and safe via online means. So thank you all for this conversation.
Thank you both for those comments. And Councilmember Glass, I knew a lot about you. I didn't know about your work with the VA. That's actually pretty cool to learn something.
I don't talk about that often because telehealth is not a topic that comes up very often. So here we are.
Great. Well, neat. Okay, so first of all, thank you. I think as a follow-up, gearing towards this public health summit, something like a blueprint, something like a plan that addresses where we can go from here, taking into account all the pros, cons, limitations, and lessons learned, I think would be helpful. So thank you so much, Dr. Rogers, Dr. Brunetto, Dr. Santiago, and Ms. Latham. This was a great presentation, and we will be following up. That segues perfectly into our final item on the agenda, which is to hear from representatives from an organization that is one of the best in the country, the Mary Center, which of course is a regional organization and whose longtime president and CEO is somebody I've admired as a leader for a long time. Unfortunately, Ms. Maria Gomez could not stay with us this morning because understandably there's a lot going on. But Dr. Elliott is here from the Mary Center. And Dr. Elliott, if you could please introduce your team from the Mary Center, that would be great. And then I will ask Ms. McMillan to tee this up and walk us a little bit through the packet and then turn it back over to you. But if you could introduce your team, we'd appreciate it.
Absolutely, Council Vice President Alvarez. Thank you very much for having us, and as well as Councilmember Glass and Councilmember Rice. It is very much a privilege to be here and an honor to have an opportunity to talk. I would like to introduce Heather Morgan, our Chief Development Officer, Leah Cheval, our Director of Care Coordination, and our newest member to Mary Center, Ari Holly Baldwin. She's part of our outreach and advocacy role. Part of the reason that we're here today, obviously, is to talk about telemedicine and how we at Mary Center have had an impact, at least what we believe, on how we guide healthcare, in particular in Montgomery County and just in general. It's like a fractured discussion, so to speak, because Leah, I would say, is like my Siamese twin in this endeavor. And so I would like to give her an opportunity also to put the slides up there, but I'm going to give a brief history of Mary Center, and then I'm going to go into the history of the telemedicine program. And so Mary Center, we're in our 33rd year. As you know, Maria unfortunately couldn't remain on the call, but we had this vision from this nurse who was working with DC Public Health, who saw these women from Latin American countries, war-torn, pregnant, needing care. Really, the genesis of this was about health equity and about, why are these women not getting the care that they deserve? And so what she did is she found a generous donation from Marion Barry, had support from Providence Hospital, started off with 200 patients, and has grown to over 54,000 patients with primary care, sonography, telemedicine, of course, pharmacy, and a variety of resources and services. And I think the biggest component of all of this is that at the foundation of everything, aside from the care that these women deserve, was also looking at the triad of social determinants of health long before it became this great term that everybody's throwing around today. And so it was focused on social services, education, and healthcare. And so again, we have 5 full service community centers, 3 of which are in DC, 2 in Maryland, 1 in Montgomery County and Silver Spring, which is our newest site online. We have 19 school-based mental health programs, 2 senior wellness centers in conjunction with the District of Columbia, and a public charter school that's co-located at 3 of our health centers. Can we go to the next slide, please? So again, our mission in Mary Center is, it's pretty self-explanatory. Excuse me, real quick. It embraces all communities, provides high-quality healthcare, education, and social services to build a better future. Next slide, please. Treating health problems alone, it's not that, we all know now, it's quite obvious. Just telling somebody they have diabetes is not the answer. And so we have to look at how is it comprehensive? How are we going to look at the dual generation education, young, old, the whole family, and how the social services are going to work to help support the family. We'll take next. So telehealth and strategies to increase healthcare access and equity. You can go to the next slide, Leo. At Mary Center, we understand and embrace telehealth as a tool to promote access and health equity. I think I forgot to mention, I'm an OB/GYN by training. I have spent 10.5 years at Providence Hospital, and I had actually delivered a large number of Mary Center patients, both through residency at Georgetown and as a student through Howard Med School, rotating through the hospitals. You can go to the next slide. And so what I'm going to do right now is I'm going to do a really brief rundown of the history of how the telemedicine program started, and then I will hand it off to Leah. In 2015, we were using telemedicine for telebehavioral health services, and we actually were using Zoom, and we still continue to use Zoom for telebehavioral health services. But we were approached by the largest Medicaid MCO in the District of Columbia, AmeriHealth Caritas, that were looking at how can they make an impact on high-cost, high utilizers, because they were saying, look, these small number of patients that are well-deserving of care are very expensive to treat, and we need to find a better, more efficient way to do so. And so they had come to us, we kicked around some ideas, and we came up with this process of what is now known as a facilitated telemedicine model. But at the time, it wasn't really something that we were calling facilitated. We actually had to call it facilitated now, simply because telemedicine, as we now know, everybody thinks of the virtual space. They think of Zoom, they think of the phone, they think of video. Well, the model that we originally started out with actually had a medical assistant who we now call a telemedical MA, who's trained in phlebotomy, who actually goes to the individual's house and has all the bells and whistles. They have a kit that has certain digital components that plug into a device. They take a hotspot, And they literally, just like I'm talking to you now, imagine if somebody's with you right there outside of view of the camera that has the stethoscope, the digital stethoscope, that has the blood pressure cuff, that has the scale, that has, the lab in a box to make sure that they can obtain any labs that are necessary, that has the pulse ox, that has the glucometer. And so these things, what we found, are very germane and relevant to a visit. And what I would say as a physician through training is one of the things that I always remember being told is 80% of your diagnosis comes from your history. And so what you find that these kind of nuanced interactions, when the person's in a much more comfortable space, you can avoid what is known to many as white coat hypertension. People get in the doctor's office and they freak out and they panic and their blood pressure goes up. Now you're seeing them in a much more comfortable, truer space. But in addition, what we also discovered in this process is that you have the capacity to identify, is there any food issues? Are there any health issues in terms of the refrigerator's empty? Is their house out of order? Are there other social components that need to be involved to help support this individual thrive? And so we started off with two providers, an older internist, which I would say older meaning that my age, which I still have a hard time believing, and a younger internist who was relatively a few years out of residency. And part of the reason we picked that is because we wanted to be able to pick stakeholders that could really break what we were trying to do, so we could actually really dissect it down to what it looked like. And once we got to that space through weekly meetings, we eventually rolled it out to the entire group of internists and adult family medicine doctors. They were gung-ho, they went with it. And as you notice that as we progressed in this history, the risk was going down, or the risk would go up. And so we wanted to make sure that we refined it based on the patient population. And then as we kept refining it, we kept getting better and better and better in what we were doing, because one of the biggest concerns with the telemedicine at that point, back in 2017 when it started, was the medical legal risk. What's going to happen if something goes wrong? What's going to happen if the patient has a bad outcome? And so once we went through that, we started seeing that there were some incredible responses, some really incredible outcomes. And I'll let Leah elaborate on that part. But as we progressed into that, we saw it took 10 months to get that with the first MCO. And then after that, it was 90 days for the second. And then the subsequent third MCO in the district said, let's get this going. And so then we transitioned into pediatrics. And then we transitioned into obstetrics. And each time along the way, there was always that reluctance. And we always looked at it with a very critical eye, but understanding that this did a number of things. Number one, it increased patient engagement. Number two, it made sure that compliance went up. Number three, we saw patients were more likely to follow up. Number four, it kept people from bouncing back to the hospital. It kept people, we were seeing people immediately after they left the ED. And so I know that there was a discussion earlier with cost savings, and I wanted to add to that because that was a great discussion what Dr. Rogers was talking about. The additional component of cost savings is it reduced the consumption of and utilization of resources that are highly expensive. So the average ED visit is like $1,300. And if you can get them and go to their house, you're actually preventing them to go there, because there's an awful lot of preventable visits. That's why they call them lanes, low acute non-emergency visits, or potentially preventable visits. So that's really the focus on how can we give them better, truer care, but at the same time make them better consumers and how they understand how healthcare is engaging to them, and really empower them on how to use that. And so as we start progressing into this newer space, we had done through, I think, the end of 2019, close to about 3,000 telemedical encounters in a facilitated space. Well, COVID hit. And when it did come, we recognized literally today is the anniversary of when we switched and pivoted to a straight virtual model, simply in the efforts of safety. We only had a small fraction of individuals that we permitted to come in: pregnant women, newborns 18 months and younger, and then vulnerable patients who the clinicians and providers deemed that they needed to come in. We switched from that facilitated model into a safer model simply because of COVID, to a virtual model with a small selection of patients. And at the conclusion of 2020, we had done close to 120,000 telemedical encounters. And what was unique about that experience is that we recognized that there were a number of things. Again, the whole focus was cost savings, but also there was a canary in the coal mine where we were seeing health equity was quite obvious. We knew there were hints of it, but it was really glaringly obvious when that happened. And so, when Councilmember Rice mentioned that about his mother, I was thinking, okay, the joke is that, a lot of times people say they're cousins. Literally last week, my mother came to my house. I was in a meeting. She had a visit with the pulmonologist. Her phone was not working with the video. And I quickly transitioned to help her do this encounter on the phone. And out of that, I follow up with the pulmonologist afterwards. Everybody's not going to have a caregiver or a son that's a doctor. But literally, he was just like, great encounter. this is the plan, 1, 2, 3, 4, 5. I was able to get enough of the history to let me understand exactly what we need to do, and she's going to follow up with me. That's where that health equity component comes in. And also the other part of the discussion that came in was about translation services. I think it's quite obvious, and there have been a lot of research articles about it, where health equity is absolutely not going to be where it needs to be and not going to go where it needs to go if we don't consider all the language barriers that are there. And so there's a lot of things that come out of this where, as this morphs, and I think it's absolutely relevant, where we say that there are certain standards that have to be put in place to make sure that we can say, let's put all these things on a piece of paper, but we absolutely need to make sure of what are the challenges that people are facing that actually prevent them from actually having a true encounter from video. Make sure that the voice is there, or I call televoice, make sure that the phone is there. But that's like a brief history. There's a large number of areas that we want to go with that, but I'll let Leah take over from here.
Hi, everyone. Thank you so much for having us. I think Dr. Elliott and I are the funniest looking Siamese twins you'll ever see, probably. So as Dr. Elliott is saying, when, it wouldn't let me advance the slides. When we were first looking at what we should do, we looked at all of the barriers to care. We looked at what was happening with our population and developed all of the facilitated model, which we already saw was improving health outcomes and cost to the healthcare system. In addition, we, as he was mentioning, we really expanded upon all of the various different services that we provided slowly, carefully, with looking very carefully at each of the individual populations that we were serving, ensuring that the participants were excited and willing to engage in this care. And now we offer, as you can see, this list is continuing to grow and grow and grow. Our model, like he was saying, is now both a virtual and a facilitated model. Our facilitated model is really, I think, where we feel most comfortable still at this point, although our virtual model has quickly become, over the past year, something that all of our participants have engaged in, or many of our participants have engaged in at this point. And we're continuing to really develop a lot of those skills, both amongst our healthcare providers and amongst our patient population. We do really strongly feel that televoice synchronous calls are also, as Dr. Elliott was mentioning, very important to make sure that we are providing for advocacy for. I think that to include in regulations and payment parity, there are many individuals who, despite even being able to operate a video and being able to connect with their provider via fancy or not fancy telehealth platforms, potentially are at work, potentially are with other people around and don't necessarily want to be seen on a screen. And I think that that's one of the things that we've also understood from our conversations with all of our participants in all of this. I wanted to show a little bit of how we've been staffing our telemedicine program. We have obviously Dr. Elliott and Dara Koppelman, our Chief Nursing Officer, work closely with me and our MCO panel managers. We have a team right now of 4 telemedicine medical assistants who go out into the home, in addition to a care coordinator who really works and supports the rest of the team with all of the additional work that we know goes into the back end of everything that happens after or before a telemedicine encounter. In addition, as Dr. Elliott was saying, we do currently have all of our providers and our entire clinical staff really working very carefully with the entire team to create and produce a successful telemedicine encounter. Some of the benefits that we've been able to see with our patients, we've definitely been able to see more accurate biometrics. Like Dr. Elliott was saying, some of that white coat syndrome has really been significantly reduced when we're actually taking a blood pressure in the home. We also see a lot of time saved, and a lot of the things that our participants mentioned to us is, it was really wonderful that I didn't have to necessarily take the time on the bus to be able to go into the clinic, have to wait in the clinic to be seeing my provider, and then the entire trip home as well. In addition, they really do get a lot of personal attention from our telemedicine and teledental medical assistants. We ensure health literacy, digital literacy. We can work through with, if we were to provide a blood pressure cuff into the home, we can actually do the education in the home with the participant. We work with their medication. We have them actually bring them to us and, work through their medication history, both with their provider, but then after the visit, make sure that a participant really understands how to utilize, when to take the medications, etc. In addition, with scheduling, we do have a very specific phone number, and each of our participants gets that individual medical assistant's phone number to be able to connect with them directly. We have, the numbers shown here in terms of encounters that we've produced by practice area, and I apologize, I think that these were updated in November, so they are further updated. Our behavioral health service line has now seen about 49,000 participants, adults, pediatrics, medication-assisted treatment, our perinatal population, and some of our dental population as well. And as you can see, as Dr. Elliott was saying, March 18th of 2020, the yellow line that you'll see here is our steadily growing facilitated telemedicine program. And then obviously our virtual telehealth care has really skyrocketed over the last year. That said, we really continue to see quite a number of people via facilitated telemedicine. And often what may happen is when a provider sees somebody via virtual telehealth and says, you know what, I really feel like I need those vitals, I need labs drawn, or I need some additional information. If that participant is unable to come into the clinic, they might call on the facilitated telemedicine team and say, I'd really like for this patient to be seen, even though I was just able to see them over virtual telehealth. As you can see, we've served about 44,118 unique participants via telehealth, and that number was updated into February. So as you can see, we've really managed to be able to connect with all of our participants at Mary's Center, who cover a very wide array of languages, immigration status, races, everybody, sex, everybody. In addition, you can see that about 5% of our population was utilizing telehealth for behavioral health care before COVID hit, and now it's about 94% of our patients see their behavioral health provider successfully via behavioral health. In addition, we understand that in the medical environment, there is a real need to put hands on a participant at various different times. And so about 50% of our population in our medical service line has been able to see a provider via virtual telehealth or facilitated telehealth since COVID started. Some of the things that we've been able to see in terms of our encounters, I know that Dr. Rogers was mentioning, some of that cost savings does come from the no-shows. For our virtual telehealth rate, we have seen our no-show rate or our in-person rate is at about 18% of a no-show rate, which is somewhat significant and certainly affects us. In the virtual space, it's dropped to about 8%, which is significant. Further than that, we, in our facilitated telemedicine program, because we're physically going out to the patient in their home, we do a lot of connection with the participants prior to the visit. We've seen a drop to about 16.7% of a no-show rate. In addition, we have noted that the reschedule rate for those visits is even lower as well than our in-clinic as well. Some of the things that we've been able to see in terms of success, a 20% drop in low acuity non-emergent visits to the ER. And that's, I think, what Dr. Elliott was saying is where we've seen the real cost savings come into play. We've also managed to improve A1C and blood pressure control by about 9% and really have enhanced this idea of patient satisfaction, enhanced care coordination with our participants in the facilitated telemedicine space. Some of the anticipated long-term outcomes that we're hoping and looking to achieve with this program and that we've already been able to see include things like access, continuity of care, and care coordination. We already have seen some of these things and hope to continue to see a lot of it, but improving adherence to well child exams and to prenatal exams, to chronic care follow-up treatment plans, all will lead to improved health outcomes. In addition to that, increased care coordination and connection with the healthcare clinic overall. In addition, we're really hoping to see that this ultimately reduces inequities in primary health care, hospital readmission, overutilization of the emergency room as well. So some of the things that we are currently working on, we did just receive a grant where we can hopefully implement our facilitated telemedicine program to a very small select number of individuals in Montgomery County to use as a pilot program to show that our facilitated telemedicine encounters really do help with health equity and access and improve health outcomes. In addition, we're working with the Clark Foundation to expand some of our telehealth services, specifically in the prenatal and postpartum environments. We are testing out a new device that allows us to do antenatal testing in the home so that we can hopefully keep pregnant women out of the labor and delivery units, and also increase access to maternal fetal medicine as well. We are also working with the United Healthcare on a community catalyst program to connect with Shepherd's Table and create some partnerships where we're capable of working together. People come for the food, homeless individuals will come for food, and we'll be there with the healthcare in the same space that they are. And then finally, we're working with the American Cancer Society and Pfizer on a community-based prostate cancer pilot program, where it's very similar to, and a lot of these programs are very similar to what Dr. Rogers was talking about with the hubs. We actually call them pop-ups at Mary Center. But really trying to set up some of these pop-ups where we go and put our services into a place where others can easily access us. It's not an only solution, it's a part of the solution. If we can get people to come to us, and if we can go more to where they are, connect them into our system of care, we can then offer additional services to them, and we can help to connect them not only to Mary Center medical services, but lots of services around the county. So I'll go a little bit into the kiosks and pop-up sites that we're suggesting, and into some of the things that we're looking to complete. And then I'll pivot back to Dr. Elliott to talk a little bit about some of the chatbots and artificial intelligence solutions that we're also hoping to engage in eventually. But with our kiosks and pop-up sites, what we've suggested and had some conversations about are going into existing school-based health centers, healthcare deserts, some senior living communities, low-income housing developments, community centers, wellness centers, and really setting up a space where we could have some type of kiosk or a hub where there would be the equipment set up already for others to use. But in addition, bringing a facilitated telemedicine MA to that space, probably once a week, maybe twice a week, but on a day that is consistent, so that people know that on this day, I can go have my blood pressure checked, I can go get my labs drawn, I can connect with my provider, and there will be consistency of care there. With remote patient monitoring, we are also handing out various different medical devices, pulse oximeters, glucometers, and really one of the things that we're hoping to do with these pop-ups is to ensure that we can educate the participants who are coming to the pop-ups on how to utilize them appropriately so that they can then connect with our providers as well. We're also exploring a virtual urgent care to increase access to our participants and increase or further decrease that low acuity non-emergent visits to the ER. So we know that there are various different people who will, rather than call the triage line or rather than call their provider, will just go straight to the emergency room. So we want to be able to provide access, additional access to a provider via telehealth for urgent care appointments. And with that, I'll go back to Dr. Elliott to talk a little bit about chatbots and artificial intelligence.
Thanks, Leah. One of the things that about remote patient monitoring is that there's an assumption that everybody has connectivity. And so remote patient monitoring also doesn't necessarily mean you actually have to have it connect into the device if you don't have the device. But when you have the telemedical MA, or if you have a virtual encounter and it's in a virtual space and you can actually visually see the numbers and the data that's coming out of it, then you have that information there on hand. There are some other features to it. One of the things I think I forgot to mention is that we had worked with the MCOs to come up with what is called a telemed kit. The telemed kit is provided through a DME company, durable medical equipment company, that will actually give a scale, a blood pressure cuff, a thermometer, pulse ox if necessary, and even a tape measure for pregnant women to measure their belly to find out their gestational age and their growth. Certainly there's concerns about that. It requires some element of instruction and understanding. That's also done in concert. These visits are not back-to-back. They're visits that are interspersed with in-person visits so that there is some element of control and understanding how to make sure that the information is validated. The chatbot and artificial intelligence, we've been talking about this probably about 18 months, but again, COVID, and that changed everything. And so one of the things about chatbots is and artificial intelligence, it's only as good as the person that's writing the code. And if you look at the research that's out there, there's a lot of unfortunate scenarios where chatbots and artificial intelligence, quite honestly, are just racist. They are built from the lens of the individual writing it, and it doesn't mean that there was a level of intent or it was intentional at all. I would like to just call them blind spots. And so it is our job to make sure that we work together with our team internally to say, what does that conversation feel like when you're engaging with a patient, for example, with Ryan White? What does it feel like when you're engaging with the patient if they're pregnant? As an OBGYN, it's normal for me to be on the phone with somebody after hours. I've never seen them before, but I have to pull and extract that information out of them to render an assessment and a plan for them to determine if they're going to go into the hospital or stay at home, sight unseen. And that's all by phone. This is not something that's unfamiliar to anybody on this phone. We're normal. It's functionally normal for us to think, call your doctor, call your OBGYN, because you're looking to seek that information. And so the goal is to use these kind of interactions in a much more natural feeling setting, written from the perspective of people that are from the community and people that engage the patients, and actually with the stakeholders involved, including the patients, to guide that in a manner that is able to readily provide them access to care and ultimately drive them in the direction that they need to go to make sure that you can expand the workforce capacity because you've now extended your arm in this space. Understanding that it's not meant to replace anything. There are nuances to actually a provider encounter, but there are things that we can do in a virtual space, as we've seen now through what we've discovered with telemedicine. The last thing is that when you have a series of providers that are out there, there's a ton of different products on the market. So it's really great to have an option of choice to find out what works right for you. And so what we discovered is that, Zoom Healthcare is great. DoxyMe is great. All of them were not prepared for this quick pivot that occurred in spring of last year. And all of them were scrambling to come up with a model that actually made sense. And so, there's things where they are looking to integrate translation services. They're looking to integrate a variety of other things. And so that's where we look at this future virtual space of the chatbot and artificial intelligence should go.
So again, thank you all. We're excited to answer some questions, and we appreciate you allowing us to come.
Wow, that was remarkable. That really was the perfect segue, because the work that Dr. Rogers and his team have set up, and that framework is now embodied in what you have been enacting since 2015 and have refined over the last year. And the fact that you guys knew what Zoom was before any of us did is not a surprise, because the Mary Center is always so forward thinking. But really, just I was blown away by the level of depth, how you're using innovation, how you are crossing it over to ensure equitable access, equitable care, and the real intentionality in making sure that this is done right is so evident in every aspect of how you are all rolling this out. It's really remarkable. So I really just want to thank you all for all that you have done, will do. It's truly amazing. I had a couple of questions. So how does this work internally within the Mary Center? Is there a team that is specifically developed to focus on the IT infrastructure issues, or do you add this as an element to each one of your different divisions, teams, and then how have you noticed the difference between the implementation of this? Because you guys are regional. How have you noticed the implementation of this? Have you noticed the difference in implementation depending on what your jurisdiction you're in? Just curious as to that internal administrative framework and what that looks like. How organic or organized is it? It's probably a little bit of both, but then also discussing how this varies from region to region.
Yeah, and I'd like to have Leah support me in my response. I would say that this process started the same way Mary Center started. It was just an organic process, and it is something that wasn't like, okay, it has to fit in this box, it has to go with this process. It started off with saying, okay, let's throw everything on the table and what do we have? And let's just strip it back and make it as simple as possible. And again, I lean heavily into my experience as an OB, and in the OR, we're not there to waste time. And if you give me too many things, I'm not going to use it. I'm not going to consume it. And so the whole perspective is to look at how can I get what I need to move as fast as possible. And when we roll IT into this, we rely on them to tell us what their capacity is, and then push back on them to say, think outside of that. Why not? Instead of saying why, we're always saying why not? Why can't we do this? And so it forces all of us in this circle that we're working with to really think about different ways. And whether or not it hits us at 2 a.m. or whether or not it hits us in the middle of a meeting, that's the beauty of how all this happens. And so I would say that there's no designated person internally that says, okay, this is the actual lead for how it works. I would say that the team ethic is that we actually have points in meetings where it's whether or not it's senior medical leadership, whether or not it's the medical directors meeting, whether or not it's the medical leadership meeting, whether or not it's the nurses having their nurse leadership meeting, that all of us bring these things back to the group and say, this is our experience and what can we do to make these changes occur. With respect to the difference in regional things, the July 3rd, 2018, the District of Columbia became active law, the Telemedicine Redefinition Act. And it says services rendered at home that are otherwise services rendered in the office that can otherwise be rendered at home shall not be denied payment. And it also came to change the rules and regulations in terms of what is the originating site. The way telemedicine was set up originally was that, I, as a doctor, would have to have me as a patient, and Leah, you're a doctor right now. Leah will be the specialist, the G1 oncologist. And so you'd have to have the patient sitting with me in my office while they were interacting with the GYN specialist remotely. That's not efficient at all. There's just no way you could do something like that. And so what they did is they said the patient could be at home. That's the originating site. The provider could be in the office. And that allowed us to really engage people where they were, literally meet them where they are. And so that was one of the things there. But of course, and I give DC much credit for trying to be at the forefront and push the envelope on these things, but the payment systems weren't ready for that. And so then we had to go back and go to the MCO and say, look, we need to come up with a different strategy, because it's not like we can have every patient like this, but we need to come up with a strategy to look at how do we equate this into a project that can be funded and supported and then have value towards the end. And so that's where you look at the shared savings and the cost savings on the back end. As those things started to evolve, then you started finding these executive orders that came out, and the executive orders really unleashed everything. But because we were in this space already, we were still so hyper-focused on safety and patient protection and privacy protection that we didn't want to just take any product off the shelf and say, okay, use your phone and start doing this right away. We wanted to make sure that we knew that these executive orders were going to sunset. And so we needed to be prepared in advance when they did. So we were going to really examine what were the options out there on the market so that when that order ended, that we weren't caught saying, okay, what do we do right now? We already have something that we're in a comfortable space in what we're using. As far as the internal admin framework, Leah's team, and I'll hand this off to her, she does an incredible job of guiding that team and pushing back on the providers, and then pushing over to me and saying, hey, look, And then I have to answer to Leah and say, okay, it's my job to get the providers to adopt into this and see what we can do. So Leah, after you.
Yeah, I think that, thank you. I think a lot of exactly what you're describing is exactly the way that it happens internally. It's not something that everybody said, okay, yes, let's go, and continues to say, like, yes, let's go. There's constant pushback, and there's constant ideas and innovations that are happening, and I think that it's really one of those spaces where we're really lucky to have this constant confluence of our entire care team. It's not, and that was pushed certainly by COVID, where originally it was really just a provider that needed to engage with a participant in this way. And so, initially it was a little bit of a rocky road, and continues to be a rocky road with certain providers. But I think that now that this is kind of the norm, that it's something that everybody is striving to improve their own skills on, and really to try to see the benefits of what it is that we can do with telehealth. I have providers in the home, and we encourage this completely, that understand that, when we're in the home, we can actually get an environmental assessment, which we could never get in the sterile environment that we bring them into in our home. If you have a child, and I come at it, like Dr. Elliott comes at it from an OB perspective, I am nearly a pediatric nurse practitioner. And so I think, if you think about somebody with asthma and allergy issues and eczema, and you bring that child into the home or into the clinic, you don't see everything that they're facing at home. When we see them in the home, we can see that there's mold in the bathroom. We can see that there are rodents or cockroaches or other kinds of things that are affecting that may be exacerbating some of the issues that they're dealing with. And so rather than just a provider just saying, here's a cream, here's a prescription, we can actually say, you know what, let's look at the root of this issue. Let's kind of dig a little bit deeper. And now I'm going to engage my family support workers, and I'm going to engage the rest of the care team to actually help to mitigate some of those things that everyone is facing. So I think telehealth is this tool where we're actually capable of really enhancing all of those services too. But yeah, it's still constantly a struggle, and it's still something that it's a happy struggle. It's something that is exciting and new, and anything that is exciting and new is going to be something that not everybody says, gung ho, let's dive in.
Yeah,
I want to.
Yeah, go ahead.
Can I add to that real quick? Sorry.
Yes.
Is that the payers took a leap of faith with us. Mm-hmm. They, I would be remiss if I did not give credit to AmeriHealth initially, and then Care First, now Trusted, now Care First. They took a leap of faith. They weren't mandated to pay for this service and this product. They actually said, come up with a solution. Let's work together and let's see if we can find something. And, from the perspective of providers, we don't hire anybody that's not going to be comfortable in that space. We literally ask them, are you comfortable with telemedicine? And if they say no, we wish them well. We know they'll be great, but it's just not a good fit for us internally at AmeriCenter.
That is powerful. And where I was going with this, there is a new profession that's emerging here, because it's not a traditional technology position. It's not a traditional healthcare position. This is an innovation officer that is unique and has a skill set and training in public health, whether it be medical or it's really interesting. You guys are on the cutting edge. And I think to really meet the full potential moving forward, there is going to have to be somebody within clinical offices who's focused on thinking about how can we push the envelope, and has the skill set or the ability to connect those dots in real time, which I think is just has immense possibilities. You guys you're heading in that direction. It's amazing. The other just point I'll make is, our African American Health Program and Latino Health Initiative have stood up specific strategies to address COVID. And a couple of the innovations that have come out of that work is, for example, within our African American Health Program, this development of a network of Black doctors, because obviously conclusively studies have shown, Black doctors and Black patients have better outcomes. And the same is true within our Latinx community. For obvious reasons, you understand, you feel more comfortable, you have the context. it's just common sense that you're going to connect better with your medical practitioners if you're talking to somebody who better understands where you're coming from. I think that's another additional benefit of telemedicine and telehealth. It puts us in a better position because unfortunately there are just not currently enough minority medical practitioners that are out there to meet the immense demand for us to fully and holistically address some of these disparities in public health. But I think we can be more intentional, and this gives us a fighting chance to start chipping away at some of those disparities in a way that's very real and that I think could also be very helpful. And I was really interested in this concept of AI and bias. So true, my goodness, and something we all have to be very careful about and sensitive to moving forward, because nothing's ever going to fully replace in-person care. And if we promote technologies that actually make create more problems than we're trying to solve, then we obviously have to be cautious of that. So, but I'm going to process what you guys have presented this morning for quite some time, and I think this has major applications moving forward. But with that, Councilmember Rice has some questions and thoughts.
So I'm going to pick up exactly where you left off, Mr. Chair, because, speaking of technology, it's a very interesting one. And Dr. Elliott, I couldn't agree with you more about some of the implicit bias that's there innately in a lot of our technology. It's one of the reasons why we started a partnership with Apple. Apple has set up with Montgomery College here in Montgomery County a coding hub to be able to start to work with local jurisdictions on creating a space in which entities like yours, like Mary Center, can work with programmers to design or to alter existing designs in terms of applications, programs to ensure that they're meeting the needs of our constituency. And so it's very exciting to hear that in our healthcare industry that we're talking about these things that we know, unfortunately, are innately afflicted with this implicit bias that's there. Just the nature of how questions, and we learned all too well when it came to COVID testing and what we sent out. Councilmember Albornoz knows all too well about the tireless hours that he and Councilmember Navarro spent and their staffs trying to make sure that things were culturally appropriate and linguistically appropriate. Those things that are innately a part of what it is that we just assume is okay because the programmer thinks that it's okay and doesn't take those steps. And then we know the impacts that has when people get frustrated, when it doesn't make sense as to what the question is, say, you know what, I'm not filling out this survey, I'm not trying to do this, whatever the case may be. And we know what the stakes are. The stakes are that folks get disconnected with the system, and therefore it translates into less healthcare and less positive healthcare outcomes for folks primarily of color and lower socioeconomic status. And so from that standpoint, I'm just curious as to whether you're seeing more of that beyond Mary Center. We know that your commitment is born out of your origination. And so obviously you guys are more in tune. Do you see that as a trend that we're seeing across the board? Is there more that we can do as local governments to help stand up and make sure that folks understand just how important this is and create that kind of groundswell in terms of changing the direction in which folks are going when it comes to just assuming that putting everything, just attach a little bit of technology to it, and now all the equity concerns are met?
I think that that is absolutely fantastic about Apple and Montgomery College. I mean, knowing that exists, makes me say, okay, can we be your test subject? What do you need from us? Yeah. Those kind of partnerships are the things that we're talking about it internally, but it's sort of like when you have your nose to the ground, you sometimes don't have time to look up and find out what's going on. And this kind of information is that, and I'm sure that Mary Center is not unique in being desirous of wanting to participate in something like that. I think it's great, and so I think from a perspective of what the council can do and what we see is just just keep the community health centers in mind, and recognize that we across the country that there are 1,400 entities with over 11,500 sites across the U.S. and all the entire territories that serve over 30 million people. There is a massive opportunity there for innovation to occur at ground level. Efforts like this would really be keeping us in the loop, letting us know, reaching it out there, throwing it out there would be great.
I did want to follow up on one other thing. When we talk about coordination of care, and obviously for those who come and see you for certain things, but they need specialized care, that's always been one of the disconnects that we struggle with in terms of really getting to that specialist. When we have folks with Montgomery Cares, and then we need to have that specialist because of a very unique condition, how are we doing in progressing with that, especially when it comes to our communities of color, our communities of lower socioeconomic status, who we know it's hard to build that trust. And once you've established it with one, then to try and reestablish it once again with another, understanding all of the other nuances that go in, because oftentimes in the African American Health Program, what we see is we get that initial meeting. Yes, you're hypertensive. Yes, you're this, these kinds of other things. I want to refer you to someone, as you said, with your mother and the pulmonologist. And so you say to yourself, okay, but then that next step doesn't happen, right? And so we lose then that grasp that we had on that person. What are some of the things that you've seen that's been effective, and how to address that? And then, what more can we do on our end to ensure that we can try and make that more of a seamless transition as well?
Yeah, I think it's a two-part answer, and I think Leah can certainly chime in. From my perspective, systems that are designed to make sure that the patient has the support they need in the background to follow them and track them. We do have what is called an MCO panel management team, and Leah had mentioned that in one of the slides, where they see care gaps, they see areas where the referrals need to be followed up on. We do have people internally that follow through on that. Many of these things are not things that are paid for. And so really looking at how you compensate for care coordination, and how care coordination overall contributes to the health outcomes, and those cost savings are where that money is being returned on the other side of that equation. So it's sort of like you're putting, again, an ounce of prevention is worth a pound of cure. And you're putting that little bit of prevention up front to pay for the care coordination, so that you're not dealing with these, diabetic foot ulcers. You're not dealing with diabetic retinopathy, dialysis. You're not dealing with the heart attack. You're not dealing with a lot of things, not to mention somebody walks in and there might be an implicit bias about saying, look, this, and Council Vice President Alvarez mentioned, there's a lot of things in there about implicit bias and who they are being seen by. It's not intentional. I would like to say it's blind spots, and I really don't want to be naive about it. I mean, I'm a physician, I'm part of the healthcare system, so I don't think all of us are bad. But at the same time, I recognize that if I walk in the emergency room and I haven't shaved for a few days, and I don't tell anybody what I do, and I say I'm having chest pain, there's a possibility I might not walk out of the ED. And so, these kind of things are definitely relevant. But Leah, I'm sure you can answer that.
Yeah, so I think, the care coordination is a huge passion of mine, and it's something that I think at Mary Center, we've been doing as part of our social change model for 30 years. And I think that we've been doing it very well. I think there's always improvements to be made. A couple of the things that we're looking into and that we are actively trying to pilot are things like a social determinants of health screener that we can institute across the entire patient population at Mary Center and a lot of our partner organizations like Bria Public Charter School, so that we can actually understand some of the various different things that are affecting the health outcomes. Again, kind of similar to what I was talking about before. Further than that, I think one of the things providers struggle with, even at Mary Center, we have this wealth, and there are this wealth of services, but it's really hard in 15 minutes to get a good history from your patient, to assess your patient physically, to handle all of their questions, and then on top of it, coordinate their care all in one space. And so one of the things that we're trying to do, and to remember this huge wealth of resources that we have and who to reach out to for each individual resource. And so one of the things that we're trying to do is to really streamline that process so that we at least can take out that step of a provider necessarily needing to remember, I need to reach out to this person, and this is how I submit the referral for this type of care coordination, and then it's going to get paid for, and they'll be followed up in this way. And then I have to also remember to reach out to that care coordinator to get an update, etc. So we're really trying to streamline that process by creating a single stream of a referral center for our providers, or anybody who really sees a patient for that first time and says, you know what, this patient needs additional help. They did receive a referral to a specialist or to a food bank or to wherever it is, workforce development programs, but they're not taking that next step. And so some of what's going to be involved in that too is a lot of readiness for change assessments as well, understanding and where our patients are, where they are in their ability to participate in their care too. Because I know that a lot of this, we talk constantly about what we can do for the population, but we also need them to take the leap with us, and we have to make it accessible for them to take that leap with us. I will say in DC, one of the things that, specifically speaking to the chronic care population, there are a couple of different health home models that have been put into place where we actually do get reimbursed for some of the care coordination efforts that we do make. And I know that that has allowed for Mary Center to, continue to offer those services in a more enhanced way. And I think that that's something that, we would certainly hope and look to the council and to regulations and payment reform for.
So, Mr. Chair, I would ask that we, and Ms. McMillan, that we actually look at what our current policies standards are when it comes to the compensation for care coordination, and make sure that, we can address some of these concerns. Certainly any increases that we might be able to accomplish will certainly help us in the end. I apologize, Mr. Vice President, I just have one more question. You guys are just incredible. So when it comes to nutrition, a key component of what folks, when we're talking about them being healthy, talk to me a little bit about, we have created, and COVID, of course, has made this an even larger topic about access to high quality foods that are also affordable. We know that anyone can go to Wegmans or to Whole Foods and buy organic and, all those kinds of things, but we know it's inordinately expensive. And so what's been the conversation, especially in Mary Center, where you're dealing with some folks who are socioeconomically impacted, about ways in which we can continue to ensure that they're eating healthier and, having access to some of these better quality foods?
That's a great question. We have our nutritionists are considered part of the medical team. And, that's something that is woefully not included deeply in med school. I don't know if Dr. Rogers could agree to that or not. They don't teach us enough about nutrition in med school. They teach us more about the disease state. And so we too have included them in our medical leadership meetings and our senior medical leadership and our medical directors meetings to lean on them and talk about how does it impact not just diabetes and how does it impact obesity, childhood obesity, but also how does it impact behavioral health. We understand that there are certain foods that children eat that just make them, less than where we would like them to be. And so, nutrition right now, if I'm correct, I believe in the state of Maryland, it's for dialysis and hypertension. And so it's a very narrow, very limited perspective. I understand there's reasons why they came up with that framework and that structure. But I think as we start looking at things holistically in general as society, we should do the same thing with healthcare. And that's where nutrition is a very significant component. So to your point, that is a absolute perfect example. Our nutritionists right now, they're booked all the way out through May. And it's not that there's it took us a while early on because we needed to get them incorporated into the medical team, saying this is extension of your service, just like integrated behavioral health. Same thing. If you identify something, childhood obesity, if you have a diabetic, a gestational diabetic, a pregnant mother who's diabetic, then absolutely they need to be plugged in. One of the things I just wanted to add and tack onto the care coordination thing is there should be a measure of accountability on the provider side. because if there's going to be some compensation, if there's going to be some enhancement of how that is paid, then the providers need to be accountable for the outcomes that they have. And if those outcomes aren't met, then that makes them, I guess you could say, ineligible or eligible for less compensation based on that. Because, it certainly isn't about just, hey, give me money for this. It's about, I need to prove it. I need to show you, and I need to validate our efforts to show you why.
Well, thank you very much. And so, Mr. Vice President, Chair, and Ms. McMillan, if we can also follow up on the nutrition standards, it may be something that we need to talk to our Office of Intergovernmental Affairs about some sort of potential statewide legislation as well. Certainly something that I'd be more than happy to address with NACO also. So from that perspective, I look forward to working with you guys. And I will make sure, just in closing, I'm going to shut up now, but just in closing, I'll make sure, Dr. Elliott, that you and the rest of the team are linked with Apple and the great work that they're doing, because I do think that they would love to work with you. Apple's really looking at getting more into the healthcare space. And so from that perspective, we're really looking for those kinds of partnerships. I think this would be a great example of one. So we'll be in contact. Thank you, Mr. Chair.
Thank you. We will, you read my mind as usual, so we will follow up on those items. Thank you very much, Councilmember Rice. Councilmember Glass.
Okay, I love a good, smart conversation, and y'all have teed this up, this section. I was taking a slew of notes during that PowerPoint presentation, and at some point I just stopped because I just found myself continuing to type, and, let me just pull them back up for a second. These were all metrics of success as I saw them. If I understood it correctly, 120,000 telemedicine encounters over the last year. Was that just the pandemic related, or over the last year?
Pandemic 2020. I mean, we had about 166,000 encounters overall. And so that's just for the medical service line alone.
Wow. Okay. So what I wrote was 120,000 telemedicine encounters, and then approximately 44,000 unique patients, right? So
Yes.
as we're continuing this conversation, this really good conversation about connectivity and engagement and keeping people connected because of the cost savings, right, associated across the health spectrum. So it seems to me that once somebody tapped in, logged on, I guess would be the right word, plugged in, logged on, they liked it, found it important, found it worthwhile, and did so 2 or 3 other times over the course of the year. Is that a general?
Pretty much. Yeah, generally speaking. I mean, obviously when you're pregnant, you have close to 10 visits during a pregnancy, but yeah, for the most part, yeah.
Right.
Yeah,
okay.
Absolutely.
And so the other thing that I thought was really important, because I don't want to go back on I will associate myself with all the comments and questions of my colleagues, but Dr. Elliott, you had talked about remote patient monitoring. And so that's what we're talking about here, right? The ongoing monitoring. What were either some of the hiccups that maybe you've encountered, or another side of that coin is, do we know why people didn't stay engaged, why they maybe went to their one visit, and maybe despite needing to follow up, having the medical necessity to do so, they didn't? So I'm curious what some of the drop-off rates, why they occurred.
Yeah, I would say that when people are already having an issue just with the video alone, adding in the technology and the device structure is even more problematic. It's a barrier, and it's one more thing for people to give up and just throw the towel in, like, I'm not going to deal with this. And so I think already not having the technology at home just for a normal, regular video encounter, even with a smartphone, is going to make it really hard linking the Bluetooth devices to make sure it's there. Also, the EMR systems are very much, I guess everybody's swinging for the fences. They're trying to have the perfect product, and therefore they're very limited in terms of giving people access for what is called an automated program interface, where it can plug in right away. And so you have Cerner, you have Epic, you have eClinicalWorks, otherwise known as ECW. And so that it's a measure, and it's a balance between security, and it's a balance between making sure the product is protected, and it's a balance between having a market advantage of who's going to get out there. And so you can buy all these fancy devices, but it might only run on iOS, or it might only run on Android. And so you really don't have necessarily this diverse landscape of a platform agnostic system that allows people to generally just go right into it. And so it's one thing for the consumer, in this case, the patient, to have the technology as a smartphone or laptop or tablet. And then it's another thing to actually have the systems that actually plug into whatever instrument that they're using. And so that's really been part of the barriers. And that's why we tried to overcome that by having that telemed kit, so that at least we could validate that. It would get shipped to their home. You know, we could see it on the monitor. We knew it was validated. We were going to double check that anyway in the office when they come in. And so that's part of the thing. So we kind of did an end around and flanked the remote patient monitoring technology challenges by giving them the devices. Even if they didn't plug in, we could still validate that over the video.
Well, what I love about the nature of this conversation, and I applaud the chair and Ms. McMillan for the format of it, is what you just hit upon was one of the thoughts that I had shared earlier with our county health department, right? And figuring out the digital hubs and providing those pieces of equipment to folks. But even as you're describing, there's still sometimes a disconnect, right, with that. And clearly, as we on the government side have our own residents and constituents, clients that we need to help support, I think the best practices come from you, right? And because we really can't emulate the private sector, but it's our nonprofit partners that have been pioneering this. And based on the metrics I outlined, you are doing it quite well. And so we need to stay in touch. We need to continue learning from you, because you've clearly are working with members of the community who need help, who are connected, and despite the disconnects that we're finding along the way, you're working through it. And that's what we need to emulate. And so I'm noticing the time, but I second and third the echo for a continuation of this really good conversation, because this is not going away. This is becoming more evident, and more people are going to be requesting it. And just, from the bottom of my heart, thank you for everything that you've all been doing, and the people who you've been working to keep healthy and safe during this most challenging year. So thank you very much.
Thank you.
Thank you, Councilmember Glass. So, Dr. Rogers, first of all, thank you for staying on. Really appreciate you. And I know that we've had conversations about your acknowledgement of, and your team's acknowledgement of Mary Center's leadership. Just would love your thoughts, reflections from 30,000 feet. I know you're already aware of a lot of this work, but I think, as we were talking about blueprint, like this is the blueprint in many ways. So just what are your thoughts and reactions from the HHS's team's perspective?
Yeah, wow. I'm amazed at some of the great work that Mary Centers is doing. I'm sitting here reminiscing from my time at the point of care. I know the innovation that can be applied. I've had a chance to work with Dr. Elliott with Montgomery Cares. I listen when Dr. Elliott speaks because I know that there's value in what providers say. And so for me, as kind of the policy guru, my job is to take what the providers say, what they value, what they need, what they prefer in the care. And I want to make sure I implement that into the policies that we are setting, for example, for Montgomery Cares. And so I really appreciate the great work that they're doing. So there's some lessons learned here, some takeaways here that I think are applicable to the Montgomery Cares community and providers. And so Mary Center is one of those providers. And so I look forward to working with Dr. Gales first, sharing my ideas with him, but look forward to working with the Montgomery Cares providers, Mary Center, U Council, and the department. For example, we talked about that whole American Rescue Plan. So I think that there's some opportunities there to strengthen the telehealth infrastructure for the Montgomery Cares providers. Many of the Montgomery Cares providers are asking for telehealth navigators. We've been unfortunately unable to provide some funding for that, but maybe some type of short-term grants to provide them with the ability to staff up on telehealth navigators for maybe over a 2 or 3 year period, so we can make sure that there's sustainability as we continue to. Dr. Elliott talked a little bit about monitoring and measuring quality, and so that's something that we're also very much interested in evaluating within Montgomery Cares, how we are monitoring, measuring quality, perhaps transition to some type of value-based care model where we're able to incentivize, but not only that, provide reimbursement for care coordinators, for nutritionists, for social determinants of health screeners. All those things I support and I value. So my challenge is trying to see how I can fit this in within a framework of the Montgomery Cares regulation policy, the county infrastructure. So I look forward to working with, again, the Montgomery Cares providers, the Montgomery Cares Advisory Board, you council, so we can formally kind of send those recommendations up through the department.
That's very hopeful, and I appreciate those comments, Dr. Rogers. And I'm not surprised, but happy to hear you had the same reaction we did in terms of the presentation. And I do think this is a unique opportunity with the federal funding that has become available. And I'll use a parallel example here, but I used to work for an organization called Latin American Youth Center, which was sort of the cousin to the Mary Center because they were founded around the same time, and their executive directors are longtime friends. And one of the things that LAYC pivoted to was actually teaching other youth organizations regionally and across the country how to expand their model. They, in a sense, became like advisors, guides, consultants, if you will. And I think that the Mary Center is so ahead in a lot of this space that, in addition to really enhancing their existing work, I think funding something like that, particularly in the short term, to help other organizations lift up their operations more quickly to meet where the Mary Center is now, I think would be beneficial to all of us. And I think there's some lessons learned within HHS itself on what is applicable here. So love to follow up and have some formal operational meetings to see how we might be able to do those things. And I think include them in this blueprint I mentioned earlier would be terrific. So this has been such an uplifting and hopeful and optimistic, and I so appreciate the comments and questions from my colleagues, Council Members Glass and Rice. There is more to follow up on, and I think the perfect backstop is going to be this public health summit that we're working towards in the fall. I think what we should just take a video of what we did today. That can just be like the breakout session. But between now and then, I think there's going to be probably even more innovation and updates. So thank you all so much. This has been a really, really productive and powerful morning. Ms. McMillan, was there anything that you wanted to add?
No, I just agree. It's been a terrific conversation, and we have some specific follow-ups, and I'm sure there'll be even more that you think of, and just get them to me and we'll work together to follow up on this.
Terrific. Thanks, everybody. Have a wonderful
Thank you very much. Thank you.
Thank you.
Yeah.
Take care. Thank you.
If you're 16. And then there's a few other requirements that are, you can't be convicted of buying or selling votes. You can't be